Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. I have a really interesting case here. So a patient who attended with bilateral, fully occluding, really dry, crusted, dead skin. So there's no earwax here. This is all dead skin that was formerly lining the ear canal itself. And this skin has since died and it's become desquamous, so it's shed, but it hasn't come out of the ear. Instead, it's formed into a plug and it's occluded the ear canal. Now, it's not visible at the moment, but this patient's got quite a large posterior tympanic perforation, so a hole in the eardrum. And it's really interesting because once I remove this occlusion, we can actually visualize their middle ear. And there's one structure called the round window, which I'll describe in more detail in a moment, that you can clearly visualize, and I've freezed that moment and I've annotated it for you guys. Now, it's probably the most crusted dead skin that I removed. You'll see why in a moment. So when a patient has a perforation, sometimes what can happen is that the skin can't fully migrate out of the ear. So the migration of skin all stems from the center of the eardrum. So the epidermal skin cells, the outermost superficial layer of skin, all those skin cells are all produced at the very center of the eardrum. There's a place called the umbo where the hammer bone attaches to the eardrum. So that's your progenitor site. And so after they're formed at the center of the eardrum, they slowly migrate sideways. With regards to the eardrum, I always compare it. So if you've been watching my videos for a while, I've used this comparison before. Imagine you're stood on top of a little puddle or pond and you drop a pebble right in the middle. You have those ripple effects. Imagine the pond or the puddle being the eardrum. Imagine those ripple effects being the dead skin. So it originates from the middle of the pond, and these skin cells, they migrate laterally, so sideways and towards the entrance of the ear. And as they do, they line the ear canal, so it provides that epidermal layer. But when you've got a hole in your eardrum, it's going to disrupt that migration because obviously there's a huge piece of the eardrum missing. And quite often you can get dead skin that then collects on the eardrum. It can happen with ventilation tubes, grommets as well. I have one patient that attends every month just to have dead skin removed off the eardrum. I've uploaded plenty of those videos on my YouTube channel in the past. And that's because the grommet is preventing the migration. Some of the skin still attaches to the grommet. So you can just see how dry, crusted this is. And there was a couple of moments where the patient did find it slightly uncomfortable because although I've removed the main blockage, they could still feel a bit of discomfort and irritation in the ear. So I wanted to peel this away. There was a bit of almost, I wouldn't say bleeding. There was a bit of, I'll come back to that in a moment. So that is the round window niche, and I will explain that in more detail, but it's quite an amazing view actually. It's not often we can visualize the middle ear. So you may see on the right hand side, so I said posterior perforation, but it's probably more, we call that a subtotal perforation. So a subtotal perforation is when the hole encompasses 3 quadrants of the eardrum, which it has. So if you divide the eardrum in quarters, if the perforation invades 3 quarters, which it probably has them there, but it's not towards the rim. So the rim of the eardrum is called the annulus. It's made up of fibrocartilage, and if you get a perforation that extends to the annulus and it encompasses 4 quarters of the eardrum, we call that a total perforation. But in this case, you could call it a subtotal, I would say. And you're going to start seeing the more complex bit now. So this skin, it's attached to the perforation on the right hand side, and it's not letting go. Now, you've always got to be a bit careful because sometimes when you've got skin migrating and you've got a perforation, I mean, it's possible for the skin to migrate into the middle ear cavity, which you don't want. So as I remove this off the eardrum, so the eardrum has got a lot of blood supply. There's a lot of blood capillaries there. and they are generally provided by the deep auricular artery, which is a branch of the maxillary artery, which itself is a branch of the external carotid artery, which itself is a sub-branch of the common carotid artery. So the carotid artery supplies blood predominantly to the brain, the structures around that, and as they approach the brain, they divide into the internal carotid artery and the external carotid artery, and it's the external carotid artery which then has terminal branches of other blood vessels. You have some that perfuse the pinna, the auricles, so the cartilage on the outside part of the ear, and then you have one artery, the maxillary artery, which runs anteriorly to the front part of the ear canal, and that also supplies all the jaw region. But as that artery goes towards the eardrum, there's a branch that then enters the ear canal, and that supplies blood to the eardrum. The eardrum also has a secondary supply superiorly to the top part. It's called the manubrium arteries, and that supplies the hammer bone. You can actually see those quite vividly, actually. So where the hammer bone is, you can see these blood vessels running from north to south. So the reason why I was explaining that is because this crusted skin is on the eardrum. As you remove it, it did probably rupture some of those blood vessels. There was no active bleeding, but you can see it was a bit inflamed there afterwards. But it put up quite a good fight. I couldn't use any oil because of the perforation. If the patient was satisfied, I would have preferred to kind of leave this skin, but they could still feel it being really uncomfortable. And you can imagine why. You can just see how rough this is. It's like sandpaper. So, and you can see like some skin there just curving into the back part of the eardrum itself, where the hole is. So I'm just leveraging this down. I'm going to use the forceps, I think. It's difficult at this stage actually to use forceps, so just looking at the orientation of the skin, it's very difficult to get hold of it. So there's going to be an opportunity in a moment where I can get a better grip with the forceps because the skin is in a more better position. So let's discuss the round window. What's the round window? So the organ of hearing, the cochlea, and the organ of balance, the vestibular system, which is composed of 3 semicircular canals, they're actually connected. We call that a labyrinth. Now, there's 2 kind of membranes or windows on the labyrinth. The first one is the oval window. The oval window is where the stapes bone or the stirrup bone is connected. So you have 3 bones that are connected to the eardrum. So the hammer, anvil and stirrup, also known as the malleus, incus and stapes. So when sound hits the eardrum, because the eardrum is connected to the hammer bone, the malleus bone, it sets the hammer bone in motion. Those vibrations are then transferred through the remaining ossicles, the remaining bones, the incus and the stapes. And then the stapes moves backwards and forwards, but it's connected to the oval window. Now, beyond the oval window, the cochlea, I think that's where the patient found it slightly uncomfortable. You can just see the sort of movement there. So the organ of hearing, the cochlea, is full of fluid. And so when the oval window swings backwards and forwards because of the vibrations, it's almost like a seesaw effect. It causes the fluid in the organ of hearing to travel in waves. So it causes pressure. And these waves of inner fluid travel over our sensory hair cells. There's outer hair cells and inner hair cells. And when these waves of fluid travel over the hair cells contract and they shear side to side, which then produces electrical current. And this electrical current is then transported up the auditory nerve to the brain. I think that's where the patient just found it again slightly uncomfortable as I trying to remove it. And we then perceive that as sound. Now, because you've got these waves of fluid, there's a secondary window called the round window, which we annotated earlier. And that's almost like a shock absorber. So when this fluid it's traveling in the cochlea, the round window, it's a membrane and it's elastic. So as the waves are hitting the round window itself, it moves forwards to kind of absorb all that fluid pressure. And you can sometimes see the round window when a patient with an intact eardrum, so there's no hole. You can, if they've got a very translucent eardrum, you can actually visualize it. But here we could really see it. So there's a condition called otosclerosis. So otosclerosis is when you've got this spongy bony growth that develops on the stapes bone that connects to the oval window. And when you get this spongy bony growth, you can see it just got a bit red there, but we managed to clear that. And instantly the patient felt they could hear better, and they weren't experiencing any itchiness or irritation. So I'm really pleased with that. So just going to move on to the right side. So there's a procedure called a stapedectomy to remove all that spongy bony growth, and quite often the stapes bone is replaced with a prosthesis. And during that procedure, what sometimes surgeons do to make sure the prosthesis is working, they actually then push the prosthesis or the bones backwards and forwards, and they look out for movement of the round window. So as you push the stapes prosthesis, or even just say they're not doing the surgery, but they've opened up the middle ear and they want to see if the bones are functioning fine. If you push the bones forwards, so the stapes bone is pushing into the oval window, you should then get kind of a ballooning outwards of the round window, because as you're pushing in through the oval window, fluid is being forced in the cochlea, and then as a result, the round window itself balloons out because the fluid is being pushed all the way through and bulging up against the round window. So it's a technique that I've seen some surgeons use. So just with the right side, so again, dead skin, it's all keratin, there's no wax here. I'm going to use a combination of suction and also a forceps. So interestingly, this patient, I think many years ago, I uploaded a video, and I'm pretty sure it's the same patient now that I'm thinking about it. It was the first time I've seen a double perforation. And I'm sure it was this patient, and at that time their middle ear was infected and they had 2 perforations. But then since, quite an elderly patient, so the perforations never healed, but instead what happened is those 2 individual perforations, they were adjacent to one another, they then became one large perforation, and that's the result of it now. And this patient obviously has seen ENT, and it's there was advised against surgery. So there is surgery that can be done, a myringoplasty, they can get a graft, you can get a temporalis superior graft, it's like a muscle graft, or you can even get some perichondrium from the tragus, or even some cartilage, and you just patch up the perforation, the hole. But I think as the patient's age, there was just a bit, it may have been complicated, the patient going through anaesthesia to have this procedure performed, so it was advised against. So you can see that this patient is developing an autoatticotomy, so the top part of the ear canal, the bone, has eroded on top of the eardrum, and that's quite common when the patient suffers from a retraction of the eardrums. When the eardrum gets sucked inwards, the eardrum itself, it compresses against the bone, and it can initiate bony resorption. So basically they activate osteoclasts with specialized bone cells that sit on the surface of the bone, and these osteoclasts, what they do, they break down bone tissue into its minerals, and they redistribute these minerals through the bloodstream to other parts of the body where new bone is being formed. So that bone that's missing there, it's probably being used elsewhere in the body. It's broken down, of course, but it's then recycled. And so that's normally common with a retraction of the eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.